In this section, we will look at the treatment of heart failure. There is no cure for heart failure, so the treatment goals are to improve the quality of life by managing symptoms. And since it is not possible to reverse the condition, we try to prevent or at least delay the progression of heart failure and reduce morbidity and mortality. These are the drug classes which are used in the treatment of heart failure. The first 5 drug classes: angiotensin converting enzyme inhibitors, angiotensin II receptor blockers, beta blockers, mineralocorticoid receptor antagonists like spironolactone and eplerenone. By the way, these are covered previously in the hypertension lecture under potassium sparing diuretics. And angiotensin receptor neprilysin inhibitor. So these 5 drug classes have been shown to prevent or even reverse cardiac remodeling. This refers to hypertrophy, which means increase in the size of the cells, and fibrosis, which is the formation of scar tissue in the heart. Beta blockers block the sympathetic nervous system, and these other drug classes, ACE inhibitors, ARBs, MRA, and ARNI, they block the RAAS, the renin-angiotensin-aldosterone system. Both of these systems are involved in causing cardiac remodeling in heart failure. We have covered the first 4 drug classes in the hypertension lecture, so please refer back to the hypertension lecture for the mechanism of action, examples of drugs, side effects, etc. But in heart failure, these 4 drug classes have an important additional mechanism of action, which is to prevent or reverse cardiac remodeling. Sodium glucose cotransporter 2 inhibitors are actually used for diabetes, but they have also been found to be beneficial in heart failure. This drug class is covered in another module, PATHCO 2. So in this lesson, we will be looking at angiotensin receptor neprilysin inhibitor, hydralazine and isosorbide dinitrate, digoxin, and diuretics. Angiotensin receptor neprilysin inhibitor is actually a combination of an ARB, angiotensin receptor blocker, and a neprilysin inhibitor. It contains valsartan, which is the ARB, and sacubitril, which is the neprilysin inhibitor. In heart failure, the renin-angiotensin-aldosterone system is activated. Another system, the natriuretic peptide system, is also activated. In RAAS, angiotensinogen is converted to angiotensin 1, which is converted by the ACE enzyme to angiotensin 2. Angiotensin 2 causes things like vasoconstriction, release of aldosterone, which causes retention of salt and water, fibrosis of the cardiac muscles, and ventricular hypertrophy. These effects are undesirable because they put more stress on the failing heart and worsen the heart failure. On the other hand, the natriuretic peptides, for example ANP, BNP, and CNP, cause the opposite effects from the RAAS. They cause vasodilation, increased natriuresis, which is increased excretion of sodium in the urine, and diuresis, which is increased production and excretion of urine. They also cause reduced hypertrophy and fibrosis. The peptides are broken down by the enzyme neprilysin into inactive fragments. So, valsartan, the ARB, blocks the harmful actions of angiotensin 2, and sacubitril, which is the neprilysin inhibitor, prevents the breakdown of natriuretic peptides, thus increasing their beneficial activity. So to recap, the mechanism of action of angiotensin receptor neprilysin inhibitor is that valsartan blocks the angiotensin 2 receptors and results in decreased vasoconstriction, reduced sodium and water retention, and reduced hypertrophy and fibrosis. Sacubitril inhibits neprilysin and slows down the breakdown of the natriuretic peptides. So this results in increased activity of the natriuretic peptides, such as increased vasodilation, increased natriuresis and diuresis, as well as reduced hypertrophy and fibrosis. Angiotensin receptor neprilysin inhibitor is recommended as a replacement for ACE inhibitor or angiotensin 2 receptor blockers in patients who remain symptomatic despite treatment with these medicines, plus a beta blocker, plus a mineralocorticoid receptor antagonist. Since it contains an ARB, it cannot be used in patients who cannot tolerate ACE inhibitors or ARB. For example, those who have a history of angioedema related to ACE inhibitors or ARB. Angioedema is a life-threatening hypersensitivity reaction where the person experiences swelling of the face and the mouth and the tongue. It also cannot be used in pregnancy due to fetal abnormalities, and it also cannot be used together with an ACE inhibitor. Potential side effects are hypotension, hyperkalemia, and cough. Another medication used in heart failure is hydralazine plus isosorbide dinitrate. This is a combination of two vasodilators. Vasodilators enlarge the small arteries or arterioles, which relieve the systolic workload of the left ventricle. So the heart has to work less to pump blood through the arteries. Vasodilators also generally lowers blood pressure. We have covered nitrates in angina treatment. So one of the nitrates is isosorbide dinitrate or ISDN. The mechanism of action, if you still remember, is it causes vasodilation by increasing cGMP, which relaxes smooth muscles in the blood vessels. Isosorbide dinitrate causes vasodilation in both arteries and veins, so it reduces the preload as well as afterload. And so if you remember, preload is determined by the amount of blood returning to the heart, while afterload is the pressure that the heart has to pump against during systole. We have also briefly looked at hydralazine in the hypertension lecture as a vasodilator. So mechanism of action is that it relaxes the smooth muscle in the arteries and hence it reduces the afterload. Hydralazine and isosorbide dinitrate is not used as a first-line treatment, but it can be considered as an alternative for patients who cannot tolerate ACE inhibitors or ARBs. It has been demonstrated to be of benefit in African Americans, but it has limited applicability in the Singapore context. Next, let's look at digoxin. Digoxin increases the force of myocardial contraction. This is called a positive inotropic effect. Let's look at the sodium-potassium ATPase pump. This pump moves sodium ions out of the cell and brings potassium ions into the cell. Digoxin inhibits the sodium-potassium ATPase pump in cardiac muscle cells. This causes an increase in intracellular sodium, and this increase in intracellular sodium drives the sodium-calcium exchange pump. This in turn increases intracellular calcium. The increased calcium in the cell enhances the force of cardiac muscle contraction. Digoxin also decreases heart rate, but the mechanism of this is not fully understood. Digoxin is not used as a first-line therapy for heart failure, but it does help to improve symptoms, quality of life, and exercise tolerance in patients who have mild to moderate heart failure. Besides being used for congestive heart failure, digoxin is also used for atrial fibrillation. Atrial fibrillation is an abnormal heart rhythm characterized by very rapid and irregular beating of the atrial chambers of the heart. Let's look at the pharmacokinetics of digoxin. Digoxin is a drug with a very narrow therapeutic index, and the plasma drug concentration needs to be kept within 1 to 2 nanograms per ml. So it is very important to monitor the dose of digoxin and the side effects carefully to prevent toxicity. Digoxin is also highly protein bound, and so it can interact with other highly protein bound drugs. Digoxin is renally excreted, 70% renally excreted. So renal function of the patient should also be monitored when they are on digoxin. Since digoxin has a narrow therapeutic index, small changes in the plasma drug concentration can lead to toxicity. Signs of toxicity include GI effects such as abdominal cramps, nausea, vomiting, and diarrhea. Visual disturbances such as a yellow or green tinted vision, diplopia, which is double vision, and blurred vision. CNS effects like confusion, restlessness, and insomnia. And effects on the heart, bradycardia, which is a slow heart rate of less than 60 beats per minute, and ventricular arrhythmias. The most serious side effect is the arrhythmias, which can be fatal. Hypokalemia or low potassium levels increases digoxin toxicity as well, because digoxin and potassium compete for the same binding site on the sodium potassium ATPase pump in the heart muscle cells. So when potassium levels are low, digoxin can more easily bind to the pump and exert its effects. Finally, let's take a look at diuretics. This includes loop diuretics and thiazide diuretics. Diuretics work by reducing the reabsorption of sodium in the kidney and causing an increase in water loss. For the detailed mechanism of action of loop diuretics and thiazide diuretics, please refer back to the hypertension lecture. In heart failure, diuretics are mainly used to reduce the symptoms of volume overload, for example, shortness of breath, peripheral edema, and ascites. In hypertension, if you remember, thiazide diuretics are more commonly used since they have been proven to reduce long-term cardiovascular mortality and morbidity. However, in heart failure, loop diuretics are more frequently used due to their rapid onset and efficacy in removing excess water from the body. After completing this section, you should be able to list the various classes of drugs used in congestive heart failure, state the mechanism of action of each class, identify the common drugs in each class, and state the common side effects and drug interactions.